Hello, everyone. I'm Stan Fuentes, a first-year psychiatry resident at LSU HSC. I'm here to present the efficacy of housing first initiatives in aiding homeless populations with psychiatric disorders. Homelessness is a complex social problem that has deleterious effects on health and well-being. Homeless populations have increased rates of major depressive disorder, schizophrenia, bipolar disorder, and substance use disorders. Psychiatrists encounter homeless patients in hospitals, outpatient government-funded clinics, and substance use treatment facilities. Psychiatrists must be acutely in tune with the social interventions, namely the housing first model, most efficacious in helping homeless patients truly combat mental illness. Continuum-based housing approaches have furthered the social exclusion of many people experiencing homelessness who have a mental illness or use substances. In contrast to continuum-based housing approaches, Housing First was developed on the premise that housing is a human right. The Housing First model is based on the notion that homeless people should have a rapid pathway to housing, not contingent on resolved psychiatric issues. The model is predicated on the notion that once homeless patients with psychiatric disorders can obtain permanent housing, only then can patients achieve constancy, daily routines, and privacy, and be allowed a path to mitigation of their psychiatric disease states. Harm reduction, in the context of Housing First, most commonly refers to programs not requiring tenants to abstain from using substances in order to access housing and services. Now I'm going to talk about the psychiatric outcomes of Housing First. In the US, research regarding Housing First initiatives has reported a decreased number of days in psychiatric hospitals compared with a treatment as usual approach. If we look at figure 1, the histogram shows that for the great majority of homeless people, readmission rates start to occur from days 2 to 5, the lion's share, and kind of keeps continuing if the month were to progress. Housing first models have also been associated with decreased use of inpatient, emergency, and justice system services. Figure 2 shows that, especially related to the housing first group, the proportion of time institutionalized is a lot lower for the housing first at the 6-month period. Accordingly, Housing First addresses the primary unmet need of people experiencing homelessness, housing, without requiring them to demonstrate housing readiness that could prolong homelessness or increase risk of housing loss. In a Canadian study, they showed that 6 to 24 months out from a Housing First program compared to treatment as usual, there were increased rates of stable housing, essentially averaging anywhere from 60 to 80% in different cities. Figure 4 also shows the mean cost per patient compared to a treatment as usual approach for Housing First. And pretty much shows that the relative risk for healthcare costs and residential costs went down. Alrighty, so my duty as a psychiatrist. In terms of recommendations and best practice guidelines, psychiatrists must work in tandem with social workers, nurses, pharmacists, and lawmakers to ensure that housing for our poorest patients is seen as necessary for the preservation of community-wide mental health. Psychiatrists in New Orleans should be intimately connected to housing programs such as Hano and Unity for streamlined referrals and starting the pathway to housing. Representatives from these organizations should be visiting hospitals and outpatient clinics to obtain a census for how many patients need housing. Psychiatrists should also be providing education and resources for access to local community clinics, shelters, and organizations that aid in employment and vocational skills. All right, and this is the literature. Thank you so much for listening. I appreciate it, and I look forward to presenting at Xavier.